our ischial spine. More specifically, the right ischial spine. Let me see that marker again. Good, our obturator foramen, our left obturator foramen. Good, our right PSIS, posterior superior iliac spine. Good, our right ASIS. Sorry, right ASIS, good. And then here would be our AIIS. So I just gave you that answer. So this would be our left AIIS, anterior inferior iliac spine. Remember, don't confuse the AIIS with this acetabular rim or ridge. Okay. What was this line? Good, our ilio line, or ilio-ischial line, sorry. Ilio-ischial line. It's the acetabular rim. Do you remember which one is more medial? Is it posterior or anterior? So the anterior one is more medial, and then the posterior one projects more laterally. Okay? So now we see that this one should be the left posterior acetabular rim. It's that shaded region. Yeah, our Kohler's teardrop. So again, this isn't a true anatomical structure. You only see this on X-ray. It's a confluence of different structures forming the borders of that teardrop, and you always want to make sure that that teardrop stays lucid in the middle. So again, the variant section of the hip, it can be, well, not, it's more like a simulated pathology because it looks like there's a lucency between the roof and the remainder, the medial border of that acetabulum. So this is what's known as the acetabular notch. You won't see it all the time, but it depends on how the patient is positioned. Because I don't really appreciate on that left side. Just know it can be confused with a fracture, so it's simulated pathology. Yeah, so this is part of the SI joint. We used to separate it between anterior and posterior. I don't care about anterior posterior SI joint. So whoever did this one separated it, but I'll make sure to put the entirety of that joint for you guys. So saying SI joint is completely fine. Alrighty, now we're on to a knee. There's that little indentation on that lateral side. Good, that's our popliteal groove. Perfect. You have a lateral view. Jeez. So yeah, so this would be the medial condyle. So usually, again, you would love to have the patient be as neutral in their lateral position as possible. Sometimes that's not entirely the case, and sometimes with the lateral projection, you may get a little magnification, especially on the structures that are further away from the cassette. When the patient is positioned for a lateral knee view, the lateral aspect of their knee is going to be closest to the cassette. So, so the lateral aspect of their knee is going to be closest to the cassette. Therefore, the medial aspect is going to be further away, therefore a little more magnified. So that's why that condyle looks a little bigger than the lateral one. So for number 18, what view is this before we get to it? Yeah, so this is our medial oblique view. And good, you mentioned that this was the medial tibial plateau. Perfect. Got another lateral view present. What did we say that was? Good, it's the roof of the intercondylar tunnel. So again, it's another structure that you won't typically see on anatomic structure itself, but it would represent, why is it disappearing? That's what I get for using this background. Anyways, the intercondylar tunnel is projected there, so the border above that would be that roof. Okay, this one we have another oblique view, and yeah, the oblique view is good to really assess this proximal tibiofibular joint. So a really nice projection of our proximal tib-fib joint. Good. That's that structure. Yeah, good. So for tibiotuberosity, you see it best on that lateral view, but when you turn it around, on an x-ray, you may see it projected just a little off to the side, just laterally. And that's what we're seeing. This can also be an area of simulated pathology because it can look like what's something called a periosseal reaction, but completely normal. That is our tibial tuberosity. So yeah, the base or the superior pole of the patella. Perfect. Okay, number 23. So the entire thing itself is collectively the tibial eminence. Good. Whereas this one, the tibial spine, which one? It is the left, but it's also the medial one. Remember, this is the medial side, it's the lateral side. So another name for it is the left medial intercondylar tubercle. Don't worry about that. Keep it as tibial spine. I think it's easier to remember it as tibial spine too. And here we have the lateral one. And if there's ever any confusion which side is medial or lateral, just make sure to look at that fibula. Fibula is always lateral. So yeah, so the apex or the inferior pole of the patella. Good. What's this region here? Yeah, it's above the patella. This is suprapatella, bursa or recess, either or. It's the recess in which the bursa lives. You shouldn't visualize the bursa too well because yes, it's a fluid pocket, but you don't want any excess fluid in that area. Okay, next one. So the entire thing itself is the fibular head, but more specifically, that pointed structure, yeah, it would be our styloid process.
Bye, have a good day at work.
Okay, what's this one? Yeah, it's our Hoffa's fat pad, or we can say it's below the patella, so infrapatellar fat pad. So infrapatellar fat pad or Hoffa's fat pad, good. Good, our medial femoral condyle. What view is this? Yeah, this is our intercondylar view, our tunnel view. Yeah, it is taking P to A. It is taking P to A. But just to keep it consistent, we're just going to call it either intercondylar or tunnel. So 32, as the name suggests, what we're looking at is the intercondylar tunnel. So that's the tunnel. Yeah, you can say like it's the border of the tunnel. Alrighty, next one. Quadriceps tendon, good. And then as it crosses over that patella, it then becomes our patellar ligament. So quad tendon crosses over patellar ligament. Or you can say patellar tendon too. I've heard both. But usually kind of just to I guess more anatomically correct, from muscle to bone it's a tendon, and then bone to bone is a ligament. But I don't care either way. You can say patellar tendon, you can say patellar ligament. Alrighty. What's this structure? Good. This is the talar dome. What's my favorite word? The tibial plafon. Good. So this is the tibial plafon. Next one. No, don't overthink it. Yeah, there you go. Medial malleolus. Now, what's the structure? I have foot, tilted. Yeah, good. So that's our calcaneus. That's what we're seeing there. Who can spell it right for me? The sustentaculum tali. What bone is that? Good. That's our cuboid. And that one. Good. So we can see the navicular much better projected on our D to P foot, little boat-shaped one. But good. You notice that it's still projected there. Got it correct. That's our navicular. Good. So another styloid process at the fifth metatarsal. We had a fibular styloid process, fifth styloid process, radial ulnar styloid processes.
Second distal
It's this structure here. This view is our lateral foot, and then this view here is our oblique view. Oh no, it's not. It's not really a true oblique. I think this is just a bad lateral view. But yeah, this is the distal phalanx of the first toe. So yeah, so this is just a bad lateral. They're too rotated on this one. This would be more of an oblique view. So what was this structure here? You see that it's vertically oriented. Gyrus peroneum. Yeah, this is a growth plate or a secondary growth center. Fracture would be more of a transverse orientation. So the secondary growth center comes in a vertical orientation. If it were more of a fracture, it would be of a horizontal orientation.
secondary growth center of the calcaneus.
So it does appear denser than the remainder of the bone. That's still normal in this case, as long as there's no fragmentation going on and widening at that growth plate. It's fine. It is the calcaneal tuberosity. And however, when it's still detached, we can call this the secondary growth center of the calcaneus or the calcaneal apophysis in this case here. So again, it can be more sclerotic than the remainder of the bones and a little irregular in the process. History is very important to address for this patient to see if they do have pain in that area, and then we can confirm or deny the presence of AVN. It's known as Sever's disease in this case. So remember the same separation, base shaft head goes along between the metacarpals and metatarsals. So this would be the head of the fourth metatarsal. The structure lives there, attaches onto our calcaneal tuberosity. Good, our Achilles tendon. What bone is that? Good. This is our lateral cuneiform. Good. What was this structure? Right there? Our tarsal sinus or sinus tarsi. Good. That structure there. Now look carefully. It is still attached. So this is just our posterior process of the talus. In essence, it does kind of resemble a little tail. Okay, so what's the name of that region there? I do like Tyler tail. Yeah, so this is our tarsal metatarsal joints, and we can also name this as a Lisfranc joint. So tarsal metatarsal and Lisfranc, you can use those interchangeably. And then the area that separates hind foot from midfoot is our Chopard's joint. Alrighty, normal variant. Is that one adjacent to the cuboid? Good. This is our os peroneum. Good. It's our navicular. It's superior to the navicular. This is our os supernavicularis. This one adjacent to the acetabulum. Yeah, os acetabulum, os acetabuli can be associated with FAI. Just know that that's an os acetabuli. That structure there. That little focal lucency. Not a nutrient frame, and those would be a little smaller. Yeah, this is our herniation pit, our synovial herniation pit, or a pit, or Pitt's pit. Again, This one can also be associated with FAI. It says that the patient does have a little bit of a cam type impingement. It just means that the femoral head isn't as rounded between the junction as it should be. It's almost like one note when you're looking at that junction there. What's going on here? Good, a bipartite patella. We have a 7-year-old. At this age, this should have already been developed. Yeah, so we have bilateral agenesis or aplastic patellas. So patella should be well on its way to full ossification by 5. We saw it in the hand earlier. Now we have one in the foot. Another example of polydactyly. Again, it can be an isolated anomaly or associated with other congenital conditions. We have this going on between the calcaneus and the navicular. It's a coalition. Do you remember what that sign is called? You see that anterior process is a little more elongated. Yeah, so it's, you're seeing an anteater sign. So calcaneo-navicular coalition, anteater sign. Here we'll see a continuation between the talus and the calcaneus. This is our C sign. Makes a backward C that shows there's continuation between the two. So normally we should be able to see separation between the subsyntacculum tali and the talus. And you see the posterior process is detached. So yeah, so this is our os trigonum. You guys got there. You got there. See this little ossicle in between the metatarsals. Good. This is our os intermetatarsium. I know some of you have been itching to say it, so say it now. It's this one. Yeah, this is our os tibiale externum. And again, this one can have 3 different instances of it. You'll have an osticle, and then you'll have, or you can have an elongated navicular, which could be called an os naviculare. Don't worry about that. I'll just show you the detached one, which is our tibiale externum. Oops. Sorry. All right, there we go. See these notches at the ilium. Got our paraglenoid sulci. Say paraglenoid fossa, paraglenoid sulci, paraglenoid notches. All of them, all of those are acceptable. All right, and that was it for that. And just really, really quickly, I just want to project some images. Yes, you do need a second device for tomorrow. Something to project on camera, and then something to take the exam.
Is our quiz up, our midterm up on Examplify already?
Not yet. I haven't posted yet, but it'll be available by tomorrow. 50 questions, 70 minutes. "30 questions will be with imaging, 20 will be without. Alrighty, so do we have, what do we have here, an MRI or a CT? No lecture after the exam. Axial, sagittal, or coronal view? Yeah, so this is a sagittal view. So this little insert down here at the bottom, this is showing me an axial view, but it's that yellow line that's cutting across is showing me where that slice is. And we're going from the most lateral aspect down to the most medial. So that's what we're seeing here. So we have a sagittal MRI. As opposed to this one, it says MRI or a CT. So this is also an MRI. So remember, when you're looking at the cortical bone, the outer margins of that bone is going to be black for MRI, as opposed to what we're seeing in this example. You see the bone is white, very similar to X-ray. Axial, sagittal, or coronal? This is an axial MRI. Again, shoulder, we see humeral head and glenoid. This is a T1 MRI. But I'm more concerned. I'm more going to ask between MRI and CT for you guys. And maybe region too. Axial, sagittal, or coronal for the plane. This is a coronal, and this is also an MRI. And what region is this?
Your wrist.
This is the wrist. We see radius, ulna, we see carpal bones, and a little bit of that first metacarpal, or fifth metacarpal, sorry. So again, just make sure to look at that cortex. Outer margin of the bone, black on MRI. White for CT, same as X-ray. And just familiarize yourself with axial plane, versus sagittal plane versus coronal plane. Okay. Oh, got a lot done today.